Would everyone please be seated? Okay. Okay, I'd like to basically welcome you all to the 12th annual SIEPR Summit. Please turn off your cell phones and put all your devices on buzzing and mute. We stay on time here. That's an important part of this, out of respect for the speakers, many of whom have come a long way. Bathrooms are out that door to your right. And of course, I'm getting a phone call from my daughter-in-law. First order of business here is for me to introduce John Chauvin. This is the 12th annual SIEPR Summit. Okay, everybody please sit down and quiet. This is the 12th annual SIEPR Summit, and John Chauvin is the founding father of the Dirty Dozen SIEPR Summits to date, and he is retiring as director of SIEPR this year. And Mark Duggan this will be happening at midnight on August 31st. Mark Duggan will be taking over at 12:01. And so this is John's last summit. John is the Charles Schwab Professor of Economics, the Trione Director of SIEPR. I think 20 years now as the Director of SIEPR. The Buzz and Barbara McCoy Senior Fellow at the Hoover Institute. He's an economist in the fields of economic demography and social security expert. He's the chairman of the board of Cadence Design Systems. He's a member of the board of Exponent, Inc., Financial Engines, and American Century Funds. And those of you who have been to SIEPR Summits know that we do a Tinker's to Ever's to Chance sort of approach to things. So I'm going to introduce John. He's going to introduce George. George is going to introduce Elizabeth. John Chauvin.
So I hope this is not my last economic summit because I plan to be in the audience next year. But I guess you never know because I actually work on demography. But anyway, I want to welcome everybody. As Steve said, it's the 12th summit, and it's possible that somebody in the audience is unfamiliar with SIEPR, so let me just say it's the Stanford Institute for Economic Policy Research. And what we've done from the beginning is try to support research on important economic issues, whether they're domestic or global in nature. We also particularly focus our research support on young scholars. These would be postdocs, people enjoying their first sabbatical leave. We give them a great environment to further their careers, and it's worked out very successfully for us and I think for them. Now today we have, I think, an amazing day planned for you. Each year we try to at least match the previous year, and sometimes that's difficult. But I wanted to say that this day couldn't happen without the generous support of a number of organizations, particularly our sponsors, and those are Heydrich and Struggles, Dodge and Cox, and the Correct Foundation. And I know there's a number of companies that have bought tables, and then our board member have been terrific, and we had a board meeting yesterday that was wonderful. I should say, though, more than any of these groups and people, the SIEPR staff have been fantastic, and what I ask you to do is throughout the day, just thank them. Some of them have essentially been working all night to pull this off, so thank you to the SIEPR staff. And before I introduce the first session, let me just say a word about the moderator of the day, Steve Colhagen, who is the real hard worker on these summit days. He is, he's a Stanford PhD. We're very proud of him as our alum. He's a member of our advisory board. He's on a number of corporate boards, including Freddie Mac, and he's part of the cleanup team there. He retired as head of fixed income sales and trading, global derivatives and foreign exchange at Wachovia Bank. He was a professor at UC Berkeley, believe it or not, for 10 years. And he is also an author, and his latest book is called Chief of Thieves, and it's coming. I hope it's not about SIEPR, and it's coming out in June. So I recommend that book to you, and I think we'll all enjoy Steve as moderator for the day. And I also will do exactly what Steve did and say, I think I'm going to be known at SIEPR. I think my greatest accomplishment is going to be recruiting Mark Duggan to be my successor. He's going to be fantastic. Mark, stand up, take a round of applause. Just this week, Mark became an endowed professor at Stanford. He's the Wayne and Jody Cooperman Professor. This is the highest honor we pay to academics. Thank you to the Coopermans for helping us, making it possible for us to recruit Mark. It's a great honor, and I think you're going to look back and say, you know, what Chauvin did was he got out of the way for a great leader of SIEPR. Okay, now I get to introduce one of my best friends and one of the greatest Americans, George Pratt Shultz. And George, when he introduces himself, he says, George Shultz, U.S. Marine. That's the full introduction. But, of course, he has had as many cabinet posts as anybody in American history. Head of the Office of Management and Budget, head of the Treasury Department, Secretary of State. Did I say Secretary of Treasury? I can't even keep track of him. He's had so many jobs. As his wife says, he's her secretary. George has also been with SIEPR from the very beginning. To the extent I've had success, he's my secret ally. And when I panic, I run over to him, and he gives me fantastic advice. And besides feeling successful for having found Mark Duggan as my successor, another thing I'm very pleased with myself about is I introduced George Shultz to Elizabeth Holmes. George, take it over.
Elizabeth and I are going to have a conversation. We're going to sit over there, but let me first introduce her. Where are you? There she is. When John brought her over about 3 years ago, I looked at her and I said, well, I'm about to have a meeting with a friend of my granddaughter. As soon as she started talking, I did a double take. I subsequently learned that as a teenager, she went to China, learned Mandarin, got a degree from Peking University, got a job in Singapore helping with the SARS program, came to Stanford. As a freshman and sophomore, she's taking advanced courses in chemical engineering and electrical engineering. She's a dropout. She left after her sophomore year and started a company that now has, I think, over 800 employees. Its headquarters are right over here on Page Mill Road. She has a factory over in Newark. And as she and I have talked about what we're doing at the company, it has gradually come across to me, and maybe she was way ahead on this, that the most important thing we're working on is what you might call preventive medicine. So Elizabeth and I are now going to have a little conversation about that, and here she is, Elizabeth Holmes.
I've got to first say what a privilege it is for me to be here with all of you and sitting up here with with George. It's been one of the great honors of my life to be able to have him be part of our work and to learn from him.
Well, let's think about preventive medicine, how important it is. Instead of treating an illness, you see it coming and you prevent it. An ounce of prevention is worth a pound of cure, they say. Actually, in this case, it's worth about a ton of cure. In the first place, the more you do preventive medicine, the better the quality of life of people are. And then, of course, if you really start worrying about the costs of health care in this country and how you're really going to cut it down, you're going to cut it down by preventive medicine and stop all the expense of treating diseases if you can prevent them happening in the first place. So that's the idea here. And Elizabeth is nodding, so she agrees with this, but Elizabeth, let's start by explaining why this is going to take place. What are the reasons behind preventive medicine?
We strongly believe that perhaps one of the greatest challenges in our current healthcare system is that the system is built around a paradigm of what's defined as quote unquote medical necessity. So this concept that for something to be paid for by insurance and therefore to be quote unquote justifiable as an expense, you have to be symptomatic for a given condition. So for example—
Symptomatic means sick.
Sick, yeah. So if you go—
I like short words.
Yeah, good. Okay. If you go to a doctor and you're walking in effectively with chest pains, that doctor will order tests for heart disease. But if you're going in saying, I'm worried about a family hereditary risk of heart disease, the doctor cannot order those tests for risk of heart disease if you want those tests to be paid for by insurance, which means those tests don't get ordered until you're often symptomatic, because the cost of doing this type of testing is so high that an individual most often does not have the ability to afford it on an out-of-pocket basis, because there is no transparency around pricing and market forces have not really been able to take play in the context of driving down cost in this space to date. So if we can better engage the individual and apply technology toward empowering individuals to play a role in, for example, the access to health information, by definition, the more we get the individual involved in the process, the more there's going to be an understanding of prices. And
you gave me, the other day when we were talking, you gave me a little incident of something that happened in Arizona,
yeah,
where our system is deployed pretty fully. Why don't you just, for a concrete example of what happened to prices?
Sure. I mean, we offer our tests at 50 to 90% off of Medicare's reimbursement rates. And so by definition, that means a cholesterol test is $2. That's something that people can afford. And what's happening there is, because all of our prices are posted and transparent, physicians will look at that and then call other laboratories and say, if you don't drop your prices to these rates, I'm not going to give you my business. And so other companies are beginning to drop their prices. And that means people who don't have insurance or who have incredibly high deductibles can begin to afford the ability to get these tests in time for them to be meaningful, i.e. before you're sick. Right?
So the market works, but for the market to work, people have to be able to see the prices, and there has to be a competitive situation.
And we have to shift from the concept that for a medical process to be quote unquote justifiable or something that's paid for by insurance, you have to be sick, to a paradigm in which you're able to get access to those services in a preventative context. And the only way to do that is to transform the pricing model, where you drop the cost of these services. Because right now, the per service or per product cost is so high that we've built this system around these concepts of quote unquote justifiable expenses.
Let me push in a little different direction. If costs are low and the trauma of a test is reduced, there's a wonderful picture on the wall. I've got a copy of it hanging on my conference room wall. It shows the most appealing little boy you've ever seen. And he's saying very, very plaintively, "No more big, bad needle." If you can have a system that doesn't have somebody sticking a needle into your arm, and something that's much easier, and the cost is lower, then if I'm asked to take a test, I'm much more likely to do it than if the cost is high and it's going to be a needle. And you were telling me the other day the number of people walking around who have been asked by a doctor to have a test and don't do it. What's that number?
Yeah, we've seen it. We've seen it in Arizona, and it's the published numbers are 40 to 60%. We've seen it in the high 50-something percentage, and what's happening there is this concept of access. So today in our country, even when people are walking in with a symptom for a given disease, they're not following through with actually getting these tests done that are ordered for them by physicians. And so you look at that and you say, well, why is that? Well, they can't afford it, and that is one of the big problems. It's not accessible in the context of the convenience of being able to get, for example, these services done without having to leave work or take time off during the day, or they're scared of needles and these types of impediments, so people don't get tested. Well, why does it matter? The laboratory testing process, while it's a small percentage of overall healthcare spend, drives 80% of clinical decisions. So if you don't have access to that data, you're making decisions about how to take care of patients effectively in the dark. And so we have begun to look at this in the context of individual engagement, because 20%, for example, of our healthcare spend is associated with type 2 diabetes, which is a disease that is completely reversible if an individual is informed and makes decisions to change lifestyle and diet and exercise and related things. And if we can give people access to this data, if we can get them more engaged, we can begin to see that ownership and personal accountability, which will help to facilitate changes in so many of these diseases. Because right now, there's 80 million pre-diabetics in this country who don't know that they have diabetes.
A lot of this comes from analyzing what's going on in blood. So let me ask you a kind of technical question. What is there about blood that contains things that you can see that are analytically powerful? It all just looks like red and it runs, as far as I'm concerned.
People talk a lot about personalized medicine in the context of the genome, and the power of blood is that you're looking not just at your genetic composition, but also how that genetic composition is expressed over time. So you may have a gene, for example, but it may not be turned on. And what you're interested in is how does it turn on and how does it express itself based on the environmental factors that you're exposed to.
So, but what is it that you see in blood that enables you to identify those things?
So you see all those markers, those proteins,
Markers. What are markers?
Enzymes. We look heavily at the different combinations of proteins, enzymes, cells, DNA that allow you to characterize the expression of your genome and then the onset of disease effectively over time.
So, tell me if I'm saying this right. So you learn about certain patterns that are seen in blood that tell you about a potential disease. And when you see that, you say to somebody, here you are. Now, you told me one time that there is a doctor at Johns Hopkins who has figured out how to spot pancreatic cancer 17 years before it's symptomatic. That's breathtaking. But it's on the basis of seeing these markers that you're talking about. And if you have that, if you have pancreatic cancer and you know it, it's too late. But if you have this much lead time, you can do something about it. You can probably cure it with that kind of early detection.
That's exactly right. I mean, we're, as you know, doing a lot of work on that, and the ability to shift from determining you have cancer, for example, by physically measuring a tumor, to being able to see the growth of that tumor before it forms is exactly where we can go if you
And you can
make,
see that in blood.
absolutely, those tools more accessible.
Let me ask you a completely different kind of question. There's a man by the name of Muhammad Yunus, probably lots of you have heard of him. He got a Nobel Prize for his work on micro-lending, and he considers himself to be the banker for the poor. He now wants to be the healthcare provider for the poor. And here's what he does. He establishes a clinic in a poor area. There's one being done in the United States right now. Obviously, he started in Bangladesh. So he establishes a clinic. And you become a member of the clinic. You have to pay something to become a member. He believes that if you give it away free, it doesn't work. You have to pay something, and therefore you are saying, I value this. Most of the people employed by the clinic are called coaches. So most of the people, their job is to work with you, a member of the clinic, to persuade you to have a form of behavior. That's what the doctors and nurses say you should. So this is trying to get people to have a lifestyle that works.
Yeah.
And at least at preliminary efforts, it works. You can make this. So this is changing personal behavior. Would you?
Yeah, absolutely. I mean, the first step.
Can I tell Muhammad that you approve?
Yes.
Okay.
The first step in actually shifting to a model where we're focused on regression of disease is understanding and knowledge, and with that understanding and knowledge comes engagement. But, I mean, for example, until last year, it was illegal in most states in this country for people to get copies of lab results that were ordered for them by their physicians. So how you're going to get someone to reverse their diabetes or their heart disease becomes quite complicated if you're saying it's illegal for them to even access the information that will help them to understand their condition. In the same way, today, in many states, it's illegal for individuals to have the ability to order a test. And that means if they want to go in and try to start taking ownership of their health and their condition, there are barriers to doing so, yet they can, I often talk about, buy guns and shoot themselves, yet the ability to have access to their own health information is somehow considered dangerous. And until we put systems in place that enable and empower the individual to begin engaging with and understanding this information better than they understand, for example, their credit card data, which today someone would understand a credit card statement better than they would a lab report, we're not going to have that engagement, and that engagement is critical to being able to start shifting the way that these conditions play out and are managed.
So let me try to summarize. We're going to move into a more and more preventive world. Number one, by creating a situation where people take more responsibility for themselves. It's my health, so I care about it more than anybody else does. And there are tools out there that will be helpful to me, so I want to get motivated to use them. That's reason number one. Reason number two is that there are available now tools like the pattern that you see in blood that tells you pancreatic cancer is coming. So there are tools available for early detection. And if you have early detection, you can treat much more successfully and easily and more inexpensively than if you wait for somebody to get sick. So you got those two things. And then you have the notion of getting costs and difficulty down. And if costs are low, I mean, most people would say if the price is low in a market, well, it's attractive. I'm more inclined to use it. So you put these three things together, and you have momentum toward preventive medicine. So we have to work these areas, and then we'll get there. Would that be a reasonable summary of what you said?
Absolutely. I think the first step is engagement of the individual, because engagement of the individual on the one hand brings understanding and therefore knowledge, and then the ability to change behavior. And on the other hand, the engagement of the individual means the beginning of an understanding on pricing. And the more that we create transparency in the system around pricing, the more we'll see a drop in prices. And when that drop in prices happens, the more you can begin to use medical services in, for example, a preventative context as opposed to a reactive context. And until we move the system that way, we're going to be dealing with the $4 trillion problem that we're dealing with, because by the time we're figuring out someone is sick, they're already really sick. I mean, you look the word diagnose up in the dictionary and it says to determine the presence of disease from its signs and symptoms. But that's our problem, because if you're determining the presence of disease because you already have it, then you're figuring it out effectively too late to truly change its trajectory.
Now, it's still a mystery to people what it is exactly Theranos does. They know it has something to do with health and something to do with blood, but what is the basic invention that you've made? Describe that to people, and then we'll have some audience questions.
Theranos is about access. It's about the belief that we need to take that paradigm of diagnose and shift it to one. The word Theranos means the ability to determine the onset of disease in time for therapy to be effective, right? In contrast to diagnose, where we're determining the presence of disease from signs and symptoms. So how do we do that? We focused on access in the context of cost, transparency on pricing. We publish all of our prices. We are a full-service laboratory. We focused on lab because of its power in the context of driving clinical decisions. We have shifted the model. We're the first ones to go in and say, okay, if Medicare is willing to pay $100 for a test, we're going to bill them at $10. Well, what does that do? That brings down Medicare reimbursement rates, and it brings down the cost of testing. It means that someone in Arizona who doesn't have the ability to afford basic testing and drives, and we see this every day, on buses long distances to get to a testing center, can begin to afford the ability to get tested without going bankrupt. So Theranos is a lab that offers really low-cost testing. We focus on access in the context of the fact that people generally don't like large needles being stuck in their arms. So we redeveloped the lab infrastructure to make it possible to run any combination of lab tests from tiny droplets of blood. And people can come in and do full-service laboratory testing with a stick from a finger, as opposed to having the tubes and tubes taken from your arm. And we did that not just for basic tests, but for any test. And that begins to engage the individual in the testing process, because all of a sudden it doesn't hurt. We focused on access in the context of our wellness centers. So we've begun building out in every Walgreens in the country, starting with our work in Arizona, what we call a wellness center, which is a place that we try to make wonderful in the context of the experience of getting a test done. It's designed to be a place that people want to go, and we measure people's satisfaction with us around whether they walk out of a lab test saying, this is something that I love doing and thought was quote unquote fun, right? Which is just a whole paradigm shift in the world of lab testing. People don't normally say that when they get a lab test done, but it's critical for engagement. And so we're a lab that changes the consumer experience. And we're a lab that is focused on then, if we can engage people in that context of access, making the information actionable. So these wellness centers, for example, are designed to be open really late at night or on a weekend so that people can get tests done without having to go to the emergency room on a Sunday. And when you start making it possible for people to be more engaged, then it becomes possible to have that data be accessible to clinicians and individuals in ways in which it was difficult to access that information before. So the ability to get the right frequency of samples, the ability to have standardization of that infrastructure so that when physicians access that data, they have the best chance of having actionable information, the speed with which those samples are turned around. We've effectively designed a lab infrastructure whose objective is preventative care, because we fundamentally believe that until we move away from a paradigm in which we're finding out too late that people we love are really sick, we're not going to make a shift in our healthcare system.
Liz has mentioned Arizona several times. What has been done is a strategic move by the company. We are pretty fully deployed in Arizona with a hub center there, hospital, so on. And from the corporate standpoint, it's a template. So let's get one state covered far enough away so the head shed can't manage it. You got to have somebody manage it. So it's a unit of management, and it's up and running.
Arizona is a model, and you know, first we're working there to showcase what this means in terms of Medicare and Medicaid savings. Just the way we're billing as a company alone will generate $2.2 billion in direct out-of-pocket savings for Arizona Medicare and Medicaid over the next 10 years, and that's without raising taxes or cutting programs. So we're showcasing the power of technology being applied toward helping to solve policy challenges there. It's a model for the ability to showcase what the engagement of the individual means in the context of the diversity of their population. They have a very significant percentage of people on Medicare, on Medicaid, and an immigrant population, many of whom can't afford the ability to get a test done. And so what we saw over the last year as we were there was a lot of people coming to us because they couldn't afford testing anywhere else.
Switching a little bit, you have developed a arrangement with the Cleveland Clinic. So this is an example of working with a hospital system on a complete way. Want to describe that, what you're going to do with the Cleveland Clinic?
Sure. We, this was this week, announced our long-term strategic alliance with Cleveland Clinic, and I've had the privilege of working with Toby Cosgrove, their CEO, on a partnership that will deploy this technology and integrate their laboratory expertise over time to redefine the way that laboratory can be used in a clinical setting. And this is a long-term alliance that will not only integrate our work at Cleveland Clinic, but also integrate their expertise in some of the work that we do in retail throughout the country to be able to fully realized the potential for the ways in which this technology can be applied, and that ranges from what it means for an infant in a hospital to be able to get tests done from tiny drops of blood as opposed to having vials and vials taken, all the way through to the type of expertise that we have overseeing the work that's done in the context of individuals in Arizona from a laboratory perspective.
Okay, any questions out here? Everybody's stunned with no questions. There's one over here. Somebody got a mic.
I have a question on the continuum of all the things, all the diseases and everything that kills people. What % of those do you think you can find by blood testing?
It's a great question. I mean, from what we've seen, every condition manifests in the blood, right? So it's a question of understanding how to characterize that. And that's what some of this work in studying the onset of these diseases is about, because today the whole paradigm has been to look at, once you have a symptom, what are the markers in your blood? But those are not very useful markers, right? I mean, we really need to be understanding what the onset of disease looks like. As I'm sure you've read in papers, people are looking at everything from the manifestation of Alzheimer's, which is a neurological condition, all the way through to all sorts of different cancers in blood, right? Because ultimately, the body's connected. So physiologically, you will see the effect of these different conditions in blood. The question becomes, what do you measure? And that's something that we're spending a lot of time on by trying to leverage some of these changes that I spoke about on access to make it possible to get higher integrity measurements to characterize that.
Thank you, Elizabeth. Quick question about on the regulatory side. I think that sometimes the FDA has been slow on approving biomarkers in the diagnostic space. Could you comment kindly? Thank you so much.
Sure. This is a very important area, and George was asking about the work we're doing in Arizona and our work and our belief that fundamentally an informed patient is a better patient, and that this reality that individuals can't get tests ordered by physicians unless they're symptomatic so that they can be paid for needs to shift in such a way in which the individual has better access to the tests, and we can drive prices down, which will give them better access to tests and therefore more direct engagement. Well, if we're going to do that, those tests better be at the highest levels of quality. And so our company actually just recently filed a public comment in support of FDA regulation of all laboratory tests. We're the first and only lab to do that, because we strongly believe that the regulatory bar that is set by FDA is the right bar for determining the integrity of these tests. And having gone through the certified laboratory process, if you do not meet that bar, fundamentally you do not have the same integrity of testing that you otherwise would. So it is an extremely time-intensive process, and it is expensive, but if we don't realize those standards, then we can't enable individuals to get more engaged in the testing process, and we think that's a critical thing. So it's not easy, but it's the right thing to do. And our experience has been, as a small company, that it can be done, and we're deeply committed to it.
Elizabeth, can
Yeah.
you describe
Okay.
what can be done to prevent diseases occurring to patients in hospitals, staph infections, for example? What can be done to prevent that? from
Yeah.
getting out.
Yeah, this is a really interesting area, and I think there's two elements of it. One is the ability to more quantitatively monitor these infections on an ongoing basis, because right now this is a great example of a situation where by the time you have the infection, it's so far evolved that you're dealing with intervention in a highly reactive basis, and that's not even on an inpatient basis, that's on an outpatient basis, where often people are going into the emergency room because they have sepsis, and that is those types of things through more routine monitoring could be discovered much earlier. On the inpatient basis, the ability to drive down the cost of these tests makes it possible to get access to more rapid and thorough measurements of a very broad range of pathogens. And where that access becomes a reality, you can begin to make it a standard of care. And that's something that can change the way that surgeries are done and the way that people are handled in emergency rooms in the context of broad understanding of what someone is infected with without having to wait days and days.
Questions? One down here somewhere. There's one.
Yes, my question is, how early in life can this be effective? In other words, for a newborn infant, can you assess the probabilities of some of the disease occurring later in their life?
I think that's a question that a lot of different people will have a lot of different answers to. At that stage, you're really talking about measuring genetic data, and I think that there is tremendous potential there. I think there's a lot that's unknown there in terms of the actual correlation of these genes to outcomes, and that's something that a lot of people are trying to study to determine what those correlations are. I think it's complicated by the fact that we've seen that just because you have a gene does not necessarily mean you're going to have a certain outcome, because the environment, the chemicals you're exposed to, the lifestyle you lead, the food you eat, the exercise you do, all changes that outcome. So that's certainly a goal that some people have, but I think there's a lot of science that is being developed and needs to be developed to really be able to answer that question.
So I think in overall summary, we think that there's going to be a revolution in preventive medicine. You can see it in many different ways. And that is going to have a big impact on quality of life and on the costs of the healthcare system. So what Elizabeth's doing is part of that. There are lots of other parts around, but we think this is one of the most optimistic things out there about the healthcare system and its costs and its problems.
There's more questions if we...
Another question over
Yeah.
there. I thought the undertaker was coming up here, somebody who gets up and tells us it's over, but he retired.
There's questions back there. Yeah.
Is this technology going to be deployed by our local providers of medical care? And if not, when? Are we going to be able to see that with our local clinics?
Yeah, absolutely. I mean, we have a partnership with Dignity, which is the largest provider of hospitals in California, and that's a really important partnership for us.
But the business plan, if I may, is to be deployed, we're working with Walgreens, be deployed in a place that has a health orientation, but which has already located itself in a handy place where people can come, they want to be parking to be handy and so on. So that's where you are. And an outfit like that is open on weekends and open late at night usually. So that's the idea, to make it easily accessible.
Exactly.
Elizabeth, what do you see as the possibilities for the next steps in preventive in medicine? And do you see the kind of non-medical and medical working together? You talk about these wellness centers. Do you see that also being combined with anti-stress measures, exercise, prayer, meditation? How do you see those joining forces?
I think as a system, we've got to do whatever it takes to engage the individual. And so right now, this system is not designed to engage the individual. There's this fundamental sort of belief that, well, people don't know, about this, and therefore, they don't have access to this information. And every time in history where we've said something like that, I mean, that is the same argument that was made on why women should not have the right to vote, right? Because somehow they were not informed enough to be able to handle that decision, right? And today, anybody who has a daughter would probably argue with that, right? And we've made that statement in healthcare that somehow individuals are not equipped to be able to handle this information, and yet, of course they are. And to be able to take down those barriers and to do so in the highest quality way, which is why we so strongly believe in and support and are committed to the FDA framework, means that you can begin to say to the individual, here's access to this information. Well, once they have access to the information, they can start understanding it. And when they start understanding it, then the individual can choose, right? Whatever the practice is, whatever the intervention is, they can start to take control and ownership and accountability for their health. The problem right now is it's like walking into a grocery store where there's no prices, right? So you're buying these services, you have absolutely no idea what you're paying for them. There's a reason that healthcare is the largest cause of bankruptcy in this country, and so people don't engage, right? They don't get the services done. We see this every day in Arizona where people come in with piles of lab requisitions that were ordered for them by physicians because they were sick, that they didn't do because they couldn't afford it. And if we can start to shift that, then we can begin to facilitate that engagement and ownership. And yes, I mean, I hope that, across every variety of intervention, people begin to get more connected with it. And I know that every physician will tell you an informed patient is the best patient because they're actually compliant and accountable for their own health outcomes. And you take these diseases that we spend so much money on, whether it's diabetes or heart disease or something else, exercise, lifestyle matter, right, in the context of outcomes. So yes, I think absolutely we'll begin to see that shift.
This is John Taylor. Elizabeth, watch out for his question. He's tough.
I just maybe like to ask a little bit about what you're doing. It's a big structure going up on Page Mill Road. You're hiring people, you're making decisions about who to bring in and what to do, putting together a team. I mean, it's really what it's all about.
Yeah.
Maybe you could say a little bit about that.
Yeah, we have the great privilege of pursuing the incredible legacy that exists here in Silicon Valley of building something to try to make a difference in the world and to bring together a group of people who are at a point in time in their life in which they want to do the best work of their life, and they want to do something that they can look back on for the rest of their lives and know that they're going to change the world. And a lot of those come from Stanford, and a lot of them don't. And we have the opportunity to build a company that we've tried to design to be very, very long-term in our thinking and decision-making, because we really believe that fundamentally the purpose of a business is to make an impact in the world and that you can do well by doing good. And so So we're hiring people who believe in that too, and who want to work really, really hard to try to do this and try to do it right. There are these questions about FDA. This is a very difficult space, and it is a very hard bar, and it should be, because the decisions are so important and so critical. And so what we're doing is bringing together those people and trying to hold ourselves to really high standards in the way in which we operate, and trying to constantly raise those standards and create technology that can be applied toward solving challenges in policy that can help to change our healthcare system and our economy.
Elizabeth interviews everybody who's hired. There's a process, but the last step is interviewed by Elizabeth, and she wants to be sure that whoever comes aboard has a sense of mission compatible with the overall picture.
It's starting to shift now, but yeah. I have to date. It's a true statement. Yeah. There's a question there, yeah.
Thank you. Is this on?
Yeah.
You both touched on this a few minutes ago, but some people might say that long-term success in preventive medicine is going to require analysis of a lot of data and a lot of understanding of multivariate analysis and pattern recognition. So how does that fit into your business model, and how do you view that?
It's an important part of all of this, and I think it's balanced by our belief that individuals own their own data, and if they ask us to delete it, we delete it every time, and if they want it transferred somewhere, we transfer it every time, and we will never do anything with anybody's information that they don't explicitly say they want us to do ever, period. And we put that in writing in every single one of our documents, and that's the way we operate. So there's a lot of work that can be done on the research side to be able to develop those types of insights and correlations, and we were talking about some of them. Yeah, I think, it's so early in that context, and there's a lot of studies that need to be done, but I think it's a really important part of the future. Yeah. Okay.
Here's the Undertaker.
I'm the Undertaker. Thank you very, very much. That was absolutely fascinating. Before you leave the stage, I want to acknowledge a couple of things. Yes, George has held more cabinet positions than anyone on the planet, but we also have two other secretaries of defense here today, and Bill Perry and Secretary Baker who are here, and Secretary Baker was also Secretary of State. So we have two secretaries of state and two secretaries of defense here today in attendance. In addition, we should have mentioned, and I get a demerit for this, that there is a chart book in the briefcase that you came with that has a lot of information in it, not to keep you from listening to the speakers, but maybe to take away with you on a number of issues and aspects that are being discussed today. Lastly, I want to acknowledge that we have a very, very full room. There are a lot of people standing in the back and on the sides. That's not a condition which we want to encourage. So if there are seats at your table, could you raise your hand so that the people in the back and the sides can see where there may be seats? So if you somebody take the initiative to raise your hand if you've got seats at your table, and then the people in the back who want to can come sit down. Elizabeth, thank you very much. That's a great segue, a terrific segue into our next speaker. We're going to be discussing why preventive medicine has not solved what ails Europe. Sorry, Hans Werner Sins. That's not actually what you're going to talk about, but it's a perfect segue. Hans Werner Sims is going to talk about what ails Europe, and there is the question about why preventative medicine